Excellent. So welcome to the New Jersey Birth Equity Funders Alliance's learning series, Demystifying Maternal Health Data. I'm very excited about the speakers in the presentation that we are going to witness today. I don't know about you. We've heard some conversation about what data means to everyone. And for me, data has always been something that I wanted to know more about. I've always had more questions to ask than anything. But it can also be very scary and very, cumbersome to think about, especially if you're not in that field and in that understanding, right? And so the point of today is to make it as palatable for general consumption as possible. So my name is Cecile Edwards, and I'm the Senior Manager of the New Jersey Birth Equity Funders Alliance, NJBEFA for short, which is a collaborative of 4 funders, with a new funding partner having joined us this year, Organon. When NJBEFA began, it was in the spirit of collective action and toward the goal to assist and catalyze the efforts in New Jersey to make New Jersey the safest place to give birth. As philanthropists, we are complementing the efforts of government to eliminate racial disparities in birth outcomes by supporting community-based solutions and BIPOC-led efforts to address maternal mortality in the state of New Jersey. We strive to achieve this goal by supporting BIPOC-led CBOs to deliver on and expand existing work by providing resources and connecting CBO systems and services, and addressing systemic racism by funding research in BIPOC-led organizations, particularly those that would not typically receive funding. One of New Jersey BEFA's guiding principles that complements its approaches to change, mission, and vision includes uplifting collaboration, learning and co-design. Learning sessions with and for communities such as this is critical to building community and deepening understanding. These principles mimic and enhance the guidelines of participatory grant making and trust-based philanthropy, which we use as our guiding frameworks. Our principles in the frameworks of participatory grant making and trust-based philanthropy has guided us to steward several key areas of grant making. The first is CBO Insights. It's a funding to researchers that seek to use participatory data and collect information on what CBOs need, where they have been, et cetera. Technical Assistance, which is a pool of funds to pre-qualify providers to manage technical assistance services. Our Community Advisory Fund, which is stewarded by our Community Advisory Committee, which is a group of 5 to 7 experts in the birth equity field that assists us in the programmatic and operational needs of this pool of funds, which we distribute and has distributed in 2022 by giving rapid response, as well as a strategic RFP that we opened up. And we gave around 172,000 funds in 2022 across 18 grantees. And also an executive on loan, which we coordinate with Department of Health and Health Hubs to have someone who's responsible for the implementation of the Nurture New Jersey strategic plan. And so these are some of the ways that we have utilized grant making to become more equitable in New Jersey and to assist in the process of reducing maternal mortality. So we are going to jump into our introductions of our speakers today. We're going to talk about various areas. So Eugene Declercq is a professor of community and health sciences at Boston University School of Public Health, professor of obstetrics and gynecology at Boston University School of Medicine. He has collaborated on 6 reports on women's experiences in childbirth entitled Listening to Mothers, and is the creator of birthbythenumbers.org. He's also the recipient of the Martha May Elliott Award from the American Public Health Association. His recent research has focused on maternal mortality and severe morbidity. He is also a member of the Massachusetts Maternal Mortality Review Committee. Thank you so much for being here and for sharing your expertise, and we look forward to hearing more about And
Thank you. I need to take over sharing now, right?
In a moment, I'm going to introduce everyone yet. And the second speaker we'll have is Dr. Damali Campbell. Dr. Campbell is a physician board certified in both obstetrics and gynecology and addiction medicine. For almost 2 decades, she has dedicated her practice to improving the care for women in underserved areas. She has spearheaded several programs focused on women's health, including implementing centering pregnancy at academic medical centers and co-leading the College of American Pathology grant, sponsored free cervical and breast cancer screening program for uninsured women. Dr. Campbell is also the medical director for the Maternal Mortality Review Committee here in New Jersey and has many other roles and accolades to speak of. Thank you, Dr. Campbell, for being here and sharing the information that you will share about the Maternal Mortality Review Committee. It was a pleasure for me to be in a mock trial of the Maternal Mortality Review Committee, by the way, and it was very eye-opening and interesting to watch it and see what happens in real time. It was very educational. So hopefully that is something that will be done again and shared so that others can view that. So thank you for being here. And last but certainly not least, we have Mehnaz Mustafa, who is the Executive Director in Healthcare Quality Informatics of the New Jersey Department of Health. Mehnaz oversees New Jersey's Office of Vital Statistics and Registry for Health Statistics and Informatics, Healthcare Quality and Assessment, Health Services Research, and the NJBEFA Centralized Data Analytics Hub, which you'll give a demonstration on today. I'm excited to see that. And of course, Mehnaz has also been a very vital and critical member of our Community Advisory Committee for NJBEFA. So thank you all again for being here. And I look forward to being able to listen and hear what it is that you have to share. So we'll start off with Eugene Declercq. You can share your slides and yeah, looking forward to it.
Did that come up okay? Great. Thank you for inviting me. I appreciate this opportunity. What you'll see in this talk is I'm a context person for the most part. I don't have any answers. Luckily, the following speakers will have answers to all the questions you may have. My job is pretty much to define problems. And I just want to note at the outset, there we go. All my work is done with collaborators. These are all people I've published with over the years, which is a reflection of the fact that I'm incredibly old and have been around for a long time doing this, but that I've benefited from working with a very diverse group of people over the years that I've learned enormous amounts from. So I want to spend some time just clarifying definitions, because I think that's really problematic in this area. There's 3 widely used definitions of maternal mortality that kicked around, and often it's hard to tell which one people are talking about at a given point. There's pregnancy-associated death, pregnancy-related death, and maternal mortality. And I'm going to go through each one of these for a second. Pregnancy-associated deaths, death of a woman while pregnant or within a year of termination of pregnancy, irrespective of cause. This is the sort of starting point for analysis. So this is literally something usually a division of vital statistics in a state will identify through the linking of their death and birth records. It doesn't indicate that it was caused by the pregnancy. It's simply just the place to identify the maximum number of people. And that for maternal mortality review committees is usually the starting point. I'm not sure others can speak. Obviously, Dr. Campbell can speak to what happens in New Jersey. I know in Massachusetts, this is where we start, and then we review cases and make determinations of what's pregnancy related. So pregnancy related is death of a woman during pregnancy or within a year of the end of the pregnancy because of a chain of events initiated by the pregnancy or aggravation of an unrelated condition by the effects of pregnancy. Essentially, the question we all ask is, would this woman have died had she not been pregnant? And that's in the simplest terms, and it turns out it's not very simple at all, but in the most obvious terms, that's what we're talking about. And then maternal mortality is essentially the same thing. There's some slight variances, but essentially the same measure. It's asking the question, was this death caused by or a result of pregnancy? The difference is they cut it off at 42 days postpartum. And If you look at WHO figures, the international standard is the 42 days, excuse me. In the United States, CDC has been pushing the pregnancy-related measure. Same principle, different time periods. So this would be pregnancy-associated deaths. This would be pregnancy-related, right? Of all of the pregnancy-associated deaths, a subset are caused by the pregnancy, and those would be pregnancy-related out to a year. And then of these, if you do the cutoff at 42 days, you would get maternal mortality. So this is the summary of all three measures, and I'm sharing the slide. The slides will get posted to the website that I have, and Cecile has the slides, and she can post them for those who are interested as well, if you want to go through these definitions. It seems a lot to spend all this time going over this, but understand they tend to get used interchangeably, and they're not the same thing. So the other challenge is we have 3 different groups doing measurement of maternal mortality in the United States at the moment. There's the official one, which is the U.S. National Vital Statistics System, and they report on maternal mortality. In about 2.5 weeks, they're going to put out their 2021 data, an official report on the 2021 maternal mortality in the United States. And again, that goes out to 42 days. CDC has its own system called a Pregnancy-Related Mortality Surveillance System, and they put out pregnancy-related mortality. Honestly, my preference is I think their measure is a little bit more reliable than the one from the NVSS, but they're slower. The most recent data is through 2018. The National Vital Statistics System, as I said, is about to put out 2021 data on that. And then there are the state maternal mortality review committees, and they may report on anything. They may report on pregnancy associated or pregnancy related or maternal mortality, as you're going to see in a moment. For those who are interested in a more nuanced presentation of this, I wanted to include this slide from CDC, which clearly breaks down in all these terms in more detail. I'm not going to go through all of that here, but understand the differences. And what do I mean by differences? These are just covers of maternal mortality review committee reports. And notice in some, Illinois and Texas, it's a maternal mortality and morbidity report. In Louisiana, in Missouri, it's a pregnancy associated mortality report. And New Jersey, obviously, it's maternal mortality report. That's also the case in Washington, North Carolina, Alabama, and a number of other states. The key here is, as you're looking at these things, just take a moment to think which of the measures are they talking about, because they really capture different things. If you're looking at pregnancy associated, you pick up a lot of accidents, deaths, injuries that might not be considered pregnancy related, for instance. And if you're looking at pregnancy related mortality that goes out to a year, by definition, it has to be higher than maternal mortality, which only goes out through 42 days postpartum. So mostly I just want to get the word postpartum in this to confirm where I'm from, and you all can try to figure that out. Okay, again, more context, some trends in the United States. This is maternal mortality per 100,000 births, which is the standard measure over time. This red line just indicates the period at which the system had all the states involved. Prior to that, it wasn't all the states that were involved. So some of the variation you'd see here was because it was actually different states each year as they were added. But then since then, you see this major decline. And then because of the scale, having to scale it so high because of those early rates, it looks like it's flat. It's not quite. You're going to see that in a moment. This is what I meant by, this is when states started to come on. And again, it wasn't until 1933 in Texas that all the then existing states were on. I only put this slide up because I wanted to note that New Jersey was among the first states to do this. And also note that, of course, Massachusetts was as well. But this is a more recent period. This is starting in 1987, and this is from CDC's pregnancy-related mortality. And what you see is what we hear about all the time. You'll often hear that maternal mortality or pregnancy-related mortality has increased rapidly, and it very much did. But I also want to note, if you look at the pregnancy-related measure, it's essentially been flat since about 2010. And it's strange because in an advocacy side, nobody wants to say that we're doing better than we are. But in fact, these rates tend to be lower than what the vital statistics system uses. I think there's probably more false positives in the NVSS system, but it's also that it's flat. And for advocates, it's harder to say, well, we're the same. As we'll see, we may not be increasing or decreasing, but we're also at rates that are much higher than they should be. This is from CDC Wonder, which is a website one can use to draw these data. This is the more recent years. This is maternal mortality. Okay, this is out to 42 days. And it picks up, this picks up both prior to the pandemic, and you can see the impact of the pandemic, and particularly in 2021, what happened. Overall, if you just look at the rate of deaths or the number of deaths through this period, you'll see in the last 4 years, the number of maternal deaths exclusive of COVID have stayed about the same. It's a very high rate, but it hasn't really increased a whole lot. The overall rate, this is the official rates through here. I'm not sure this is the official rate. They haven't put it up, but it's going to be very close to this. It's using their data. And you can see the big jump, of course, is driven by COVID-associated deaths. The reason I have a question mark there is for pregnancy-associated deaths. Once you start with that, there's not an official code for COVID as an underlying cause of death. It can only be a secondary cause. So these are the cases that had a pregnancy-related death, right? And also had a COVID code. You can also run just the total number of deaths. This isn't a rate now. Remember, these rates are based on per 100,000 births. This is just a raw run using national data on number of maternal deaths. And what you see is pre-pandemic, it's sort of bouncing around through here. Birth rates didn't shift enormously. So this is probably close to what rates would look like once you control for that. And you see post-pandemic, you see pretty much the same thing. A pretty steady rate at about 80 per month up until late 2021, where there's a tremendous surge. And in a paper we have, I can't present the data from a paper we have in review, but the rate surges enormously in late 2021 overall in the United States. In fact, the maternal mortality rate very much runs parallel to the COVID changes through this period of time. And then 2022, they have provisional data out, and you can see the rates have dropped down some with a little bit of a bump later in the year. These are provisional. To be fair to CDC, when they put out provisional data, it's usually really close to the final data. It's not, it may be tweaked a little bit, but not enormously changed. All right, what about us, right? We always want to know, how's our state doing? This combines 4 years of data, because the feds will not report on cases when a state, if it has less than 10 deaths. So this only includes states that had at least 10 maternal deaths between 2018 and 2021. The darker states are states that they don't report on because they don't have 10 deaths. It's probably good news, right, that they had so few deaths, but it's also the fact that nobody actually lives in Vermont, New Hampshire, or Maine, or Wyoming. So there's small numbers of deaths in those cases, and there's small numbers of births. If you look at the national pattern, it's a familiar pattern for people who do this kind of work, right? Much higher concentration in the deep south of these deaths. And you can see it sort of runs through most of the South. California, Minnesota, Wisconsin all have the lowest rates less than 15. And then the states in lighter blue are less than 20. And it's sort of a northern tier of states. In a lot of these cases, it corresponds to states that have taken very strong action to deal with maternal mortality. They were early adopters of maternal mortality review committees and took a number of steps. Now, New Jersey doesn't show up relative to its importance as a national state in these maps, but if we look at exactly where it ranks, this is what it ranks, where it ranks pre-pandemic in the years prior. So it's 2018, 2019, and the first quarter of 2021. And This is from the National Vital Statistics. So but we took it out to a year. So we extended it to a year. This is pregnancy-related mortality. And there's New Jersey. It ranks 27th of the 40 states in that period that had at least 10 maternal deaths. If you look at it during the pandemic, the numbers go up. The numbers go up for all the states. Its ranking actually gets a little bit better because it didn't go up as much as many of the other states did. And New Jersey ranks 22nd in pregnancy-related mortality during the pandemic, in the period of the pandemic. Obviously, we talk about disparities, and we should. This is the black-white disparity in maternal mortality over time. And what you can see, again, in these early years, it's prior to 1933. But after that, you see this is where you hear the phrase in news reports all the time, 3 to 4 times higher for Black mothers than for white mothers. And this is the basis for it. It's actually come down a little bit in recent years. Not necessarily great news in the sense that it's good that it's gone down. It's bad that it's gone down because the white rate surged. And so that's a mixed bag. I always include this line in it. This is the black-white infant mortality ratio. And what you see here, it's about 2 times higher. And then after the late 80s, starting in the late 80s, goes to about 2.5 times higher. In the most recent year, it was 2.37, I think, times higher. This is terrible. This is an awful report that infant deaths are higher for Black kids than white. But it's consistently lower than it is for maternal mortality. And that goes to the heart of the fact that we set up a system that focuses on kids' health more than it focuses on mothers' health. And for those who, if you run into people who want to dispute this and say it's not really about race, it's about social class, it's about other things, this is the simplest explanation of it. This is black-white rates, rates for Blacks and whites by education. And what you see is for whites, the greater the education after high school, the rate goes way down. For Blacks, actually goes up a bit and then stays about the same. The net result is that for a Black woman with a college education, her chances of dying from childbirth within a year of postpartum are 60% higher than a white woman with less than a high school education. And so just we have to get past this whole stuff about its other things at work here. This puts the US in comparison to other countries. It's not a pretty picture, as you can see. In fairness to the United States, we have more recent data on the United States, and this encompasses the pandemic, right? This includes pandemic deaths. There's no death reporting from the other countries yet for 2020 or 2021. Having said that, if we just use the pre-pandemic rate for the United States, it's about here, it's about 20. So it's still much, much higher than the other countries by substantial margins. Now, again, there are those who want to excuse this by saying it's because of disparities, which is sort of an implicit, well, if it's about the Black mothers, which is silly. The easiest way to dispel this, if you looked at the white rate overall, then instead of being last, as we are with the overall rate, we would be last. And again, by a mile. And so we have 2 problems here, right? We have a system in which women are dying at much higher rates than they should overall for all groups. And we still have major disparities. Last point I just want to make, maternal deaths as a public health problem on poor women's health. We used all of the tip of the iceberg, canary in the coal mine kinds of references. This is a public health dilemma, not just a clinical dilemma. This is the best way to see that. This is from the CDC data, and they broke down deaths by timing. And I think this is really one of the most critical steps in the advocacy around maternal mortality in the United States. Why? Because look at the timing. About 13% of the deaths were on the day of delivery, about another 12% in the week after it. So about 25% happened right at the time of death, probably related to the birth or critical emergency hospitalization at that time. But about 22% happened before delivery, during pregnancy, and fully 53% happened between a week and a year afterwards. And so this means it's a public health issue as well that needs to be addressed. And if we do a great job with AIMS bundles and all of the efforts that have been undertaken that have done wonderful work to improve clinical care, we will have successfully resolved a quarter of the problem. And unless we go into the communities and work with community health, we're not going to deal with the extent of this problem that needs to be addressed. And I'll not belabor this slide. You'll have it if you want it. But I just want to note there are different causes of death at different times within this period, and we treat them differently, just as you would with any other health issue. Notably, in the postpartum period, cardiomyopathy and mental health issues manifest at much greater levels than they do at earlier times. And then remember that slide I showed you where the pregnancy-related mortality rate was pretty much flat for the last 10 years? This is overall maternal, this isn't maternal mortality. This is female death rates for women of reproductive age, women 15 to 44 over time. And what you see is a huge surge in deaths. And note the surge starts pre-pandemic, that these rates have increased enormously. And these are the rates by group. As you can see, overall, a 59% increase in deaths among women of reproductive age between 2010 and 2021. So again, it goes back to this issue. This is a public health challenge. We need to do better clinical care, but we need to really focus as well on everybody outside of the system. And notice this will be one of the findings in the paper if we get it published. For American Indian Alaska Natives, a tremendous surge in deaths that was associated with COVID as well. And instead of talking about 700 or 800 or 900 deaths, notice we're talking about an increase of about 30,000 deaths through this period of time. And so that's why I think we use the work we do with maternal mortality as an indicator of what the larger problem is, because people seem to want to pay more attention to that. Where is that coming from? Almost half of all of that increase between 2010 and 2021 came from a single cause drug-induced deaths. And actually, if you look at this over time, this is one of the few areas where the black-white ratio was going down because the white rate was increasing faster than the black rate was through this period of time until the pandemic. And so oftentimes people who focus on maternal health don't focus on substance issues. It's like different zones in the health world that people deal with. And my argument is we all have to deal with all of these issues. They're all part of the challenge. These are the cases. I'm on the Maternal Mortality Review Committee, as Cecile said, and I'm not reviewing the clinical cases. I'm reviewing these cases for the most part. And they're tragic, and they reflect a whole history of neglect from our system. Finally, just a couple things. These are rates in New Jersey. I thought this is pretty good news. New Jersey was notable for having one of the highest cesarean rates in the country for a number of years. And I'm assuming it's through the efforts of the people who are on this call that this came down, but they did. They've come down. And, you know, it's not something we're going to say we're average, but at least you're now close to the national average instead of having a cesarean rate much higher than the overall national average. And also in a positive way, infant mortality rates in New Jersey have been consistently lower than this is a typo, but lower than the maternal mortality rates, the infant mortality rates for the United States, excuse me, over time. And finally, just in case you're wondering, does politics play any role in all of these things? This isn't causal. This is just for discussion. This is maternal mortality rates by state and percent of female legislators in the state legislature. And what you see is a strong negative relationship here. The more female legislators in the state legislature, the lower the maternal mortality rate in that state. It's a strong correlation, significant, statistically significant, and something to just think about as we go forward. Thank you. I'm done. If you want this and other data, we have a website. I do it with all these students have worked with me on the website over the years. And you can just go to birthbythenumbers.org. These slides will get posted there. There's a much longer set of slides that goes over maternal mortality in more detail, as well as sets on cesareans, inductions, VBACs, all of that. And I would encourage you to go to the site. Thank you.
Thank you so much, Eugene. That was so very insightful. And I know that people have questions. We are going to hold questions, though, until the end of the presentations. So please feel free to put your questions in the chat, and we'll be monitoring that and getting to those questions and comments as well. So thank you so much. There were so many things that I learned in there that is intriguing. I even have questions myself, but I will move to our next speaker, Dr. Campbell. And I am going to share the screen for that presentation. So thank you, Dr. Campbell, for.
Sure. And thank you, Dr. Declercq. That was a tough act to follow. I will try my best so we can move on. Thank you for having me today. And I do not have any financial disclosures. You know, just piggybacking on what the Dr. Declercq said, you know, my parents emphasized education as a way out of poverty and as a way to upward mobility and freedom. And so, and that was taught to them by their parents. And so, despite the privilege that I enjoy by being college educated and even with graduate medical education, it was shocking to me to find out that it did not protect me from a poor pregnancy outcome. I have the lived experience as a birthing person who gave birth to 3 children in New Jersey, 1 that was born too soon, and 2 that remain living. And so this work is personal to me as it is to many of you. And when we talk about DEI and inclusivity, it's really showing up to the space as your whole self. And you know, unfortunately, I have become aware that oftentimes my work is not valued as much as others because of my gender and race. Next slide. So we saw in Dr. Declercq's slides, you know, these differences in the US maternal mortality rate and some of the different sources. I'm going to fly by some of the slides that are duplicated, but you know, a lot of people say, well, why? And what are some of the reasons behind, you know, why the US is, you know, so blatantly, has such a blatantly higher rate. And then we look at the death certificates, and of course we want rapid data. So, you know, some of the thoughts are maybe we're counting better now, which is probably true. Women are suffering more with chronic illnesses. Women are delaying childbirth until later on in life. And we know that there is data to support that there's a higher mortality rate for women who are over 40. And so when we quickly try to assess data on maternal mortality, we rely on the death certificate data. And so, you know, I just point out that pregnancy checkbox. And if that information and other information that's reported on the death certificate is inaccurate, then we will not have the full picture. And these authors, one of which is from the CDC, and I'm sorry that that highlight is not coming up, but essentially they report from looking at the death certificate whether this pregnancy box was accurately checked, that there were 21% false positives and 7% false negatives. So again, I'm not trying to excuse our poor performance, but we just have to understand that why there are these differences when we see the early data come out with one number and then the later data come out with a different number. Next slide. And so we saw this slide already, And again, I'll just point out, we do see the state maternal mortality review committees as really the most comprehensive way to review deaths. Our committee is multidisciplinary. We review any death of any New Jersey woman that occurs during pregnancy and up to 365 days. Those are identified through the death certificates, but also linked to fetal death and birth certificates. And so there's a lot of tracking that's done. And that's part of the reason why it takes a long time for us to get the reports and the data out. Next slide. And so I thank you again, Dr. Declercq, for pointing out, that New Jersey has been leading in this space for a long time. And so this is the history of New Jersey's involvement in maternal mortality, and we can just move on. And I wanted to point out, this is a snapshot of the Department of Health's website, and the arrow on the bottom is just pointing to where you can actually click and review the most recent report that was published on New Jersey data. So that is available for everyone's access. Next. And so just wanted to talk a little bit more about how all of this gets done. The case identification, the maternal death certificate is linked. Linkages are made between the maternal death certificate files and birth and fetal death files. And so that we confirm to make sure that the woman was actually pregnant and what happened to that pregnancy. And so we're not only reviewing women who had a live birth, sometimes we may be reviewing women who had a termination of pregnancy or even a miscarriage. Then there is the abstraction of the data, and that's done by nurse abstractors. And that is a whole process in and of itself. And then we have a multidisciplinary review committee that reviews each of these deaths case by case. And then we make determinations about the cases. And then at the end, we make recommendations. And that's probably the most important part of the review committee process, is to make recommendations that we pass on to the Department of Health and to create actions that will improve the care for New Jersey women. Next slide. So this is our multidisciplinary team for 2023. Some people on the call, and we really span many different realms. And so this legislative committee, we have representatives from the American College of Obstetrics and Gynecology, the American College of Nurse Midwives, the nursing organizations, and people, again, they bring their whole self to this committee. So even though they might be representing an organization, they also may have a background in bedside nursing or social work or data that they bring to the meeting. Next slide. And so when the chart abstraction occurs, this is what we receive. Recently, one of our abstractors reviewed a case of over 3,000 patients, 3,000 pages she had to review to abstract the chart. And then she goes through all of those, that abstractor goes through all of those hospital records. And sometimes that is from multiple hospitalizations, multiple visits, either to the ER or to the hospital, and then they come up with a summary. And that summary is completely de-identified to the committee members. So we don't have any, there's nothing to identify the hospital, there's nothing to identify the patient, There's nothing to identify the personnel that were involved. And that's really important in regards to this, the legislative process. Part of, we have the hospital records, and the abstractors have access to those records. There are some things that we'd like to have access to that we don't. If the patient had care with a private physician and that can be identified, we do sometimes request those records, but sometimes it can take a little time to go back and forth to get those records. Some people don't always understand it's not about naming and blaming. This is really an improvement process. Next slide. And so after we review the chart, the idea is for us, the committee makes 6 key decisions. Was the death pregnancy related? What was the cause of death? And do we agree with what was written on the death certificate? Was the death preventable? And what were the critical contributing factors to the death? And what are, most importantly, what are the recommendations and actions that address those contributing factors that we can move forward and the anticipated impact of those? Next. So this gives an idea of some of the recommendations that we can make. We can make them on the patient and family level, on the provider level, on the facility level, on the system level, and on the community level. And so, and then on the right-hand side, we just give some examples as to what some of these recommendations could look like after we review a death. And, just going back to Dr. Declercq's point, when we say pregnancy related, and we typically think, would this woman have died if she were not pregnant? And it seems like a very simple measure, but it's not always so simple. Particularly if we think about substance use disorder, traditionally people think, well, the person had substance use disorder before they were pregnant, so this is pregnancy associated and not related. But we know that pregnancy is a stress, that it's a change of life events. And particularly women, when they have substance use disorder, there's a lot of stress, a lot of concern about loss of custody of their child. And so those things can lead to stigma, can lead to delays in seeking care, and many other things that could impact their recovery. So just as one example, the use of a universal screening tool, a universal and valid screening tool for substance use disorder at every visit is one of the recommendations that came out of our committee. Next slide. So when we look at data, it's important to also look at the timing. After gathering data, we can try to make some generalizations and some trends that can help us to develop action steps. So in this particular, this author, looked at the reasons for postpartum ER visits. And so when we see that the postpartum ER visits are clustered in those first few days postpartum, those can give us action steps for when we might want to make warm contacts with women postpartum. Next slide. So we already saw some more CDC Wonder data about what's killing pregnant and postpartum women. And we want to know, what are those things that we need to look at? 2/3 of deaths are preventable, and we see hemorrhage on the top of the list. And so in terms of looking at facilities, how do we estimate or quantify blood loss? How do we measure blood loss after delivery? What are the best practices? We see cardiovascular and coronary conditions. We see preeclampsia. Do we start, are patients being treated prenatally? Are their risk factors being assessed prenatally, and are they being given aspirin as the ACOG and Society for Maternal Fetal Medicine guidelines suggest? Are patients being started on Lasix with severe preeclampsia? Are we sending patients with hypertension home with a blood pressure cuff? And what is the follow-up for that? So these are some of the actions that can come out of when we look at the data, the morbidity and mortality data. Next slide. We see hypertension in the US is going up. Even at younger ages, it's going up. And so that is concerning. And I think it speaks, again, more to looking at our environment as a whole, not just looking at medical care, looking at what we're eating, looking if we're exercising. And so it really encompasses all of the social determinants of health. Next slide. This is New Jersey data. And so it just reiterates some of the national data that's seen in terms of the top causes of pregnancy-related death: cardiovascular conditions, hemorrhage, embolism, and hypertensive disorders. Next slide. In our 2016 to 2018 report, all deaths due to hypertension in pregnancy were preventable, all of them. And so that just really tells us why we should be focusing on hypertension in pregnancy. Next slide. And so the challenge is really, how do we really incorporate all of the data sources into reviews? We have a lot of data from the hospital aspect. Since the legislative committee has been meeting, we've also been able to add social media posts and presence, key informant interviews. So this is where we interview a family member if they're willing to talk to us. We have incorporated DCP&P records, but there's other data sources that could assist in giving us a more holistic view of the pregnant person and their circumstances and barriers, so that we can really improve care for all New Jersey women. Next slide. I want to go back to another point that Dr. Declercq made. We can improve medical care, but we really have to address the social determinants of health, the interconnectedness of where we work and live and play is so vitally important and part of that story. And we have to address all of that if we're really going to improve our health outcomes. Next slide. And improve health equity. And again, this number was shocking for me. It's shocking for a lot of folks that, women, professional women that I talk to. And so part of the solution is that we have to address structural racism in the system. Next slide. And another important perspective that I have is that we have to, OB from North Carolina said, the mom is the wrapper and the baby is the candy. And so we get the baby out and we kind of throw the wrapper away. We throw the mom away. In my own practice, what that has implemented for me is a change. And so while, I can only change my own behavior. I can't change everyone else's behavior, but I've just started to focus on the mother. So, family, society, everybody is focused on the baby, but I'm asking mom, how are you doing? How's Jaden's mother doing? How is Alyssa's mother doing? And trying to still keep it about the mother and show the mother that we still care about her. Next slide. So quickly, as we close up, I just wanted to know if people could write in the chat if they've heard of the Maternal Care Quality Collaborative, and if they know anything about it. Just a simple yes if you know what it is. But essentially, this was part of the legislation after creating the legislated Maternal Mortality Review Committee. We also have legislation to create this Maternal Care Quality Collaborative. And the goal is to improve maternal health outcomes and really to collaborate, collect, analyze data, and then to promote action steps so that we can improve care. And I'm so happy to see all of the yeses in the chat, because a lot of places where I go, people are like, what? You know, it's like alphabet soup, and it's like nobody's heard of the MCQC. So, but we want to take the data that we have from the MMRC and also from the Maternal Data Center, which you're going to hear about in just a minute, and translate that into action and create activities that are going to help to support New Jersey women. Next slide. So I'm sure you're probably familiar with a lot of these community educational materials from different organizations, and we need to create and use them and continue to develop diverse materials to distribute to our population that are geared towards, you know, the common causes of maternal morbidity. Next slide. That's how we're gonna make New Jersey a safer place to deliver. Thank you.
Thank you so much, Dr. Campbell. I really appreciate the work that you do on the Maternal Mortality Review Committee and the MCQC. Glad to know that many people know about MCQC and the work that is being done. And appreciate you sharing your expertise and knowledge. With that said, we are going to have Mehnaz Mustafa present information. So Mehnaz, I'll give it to you.
Yep, I'm having slight technical difficulties, so just bear with me. Okay, can everyone see my slides? Yeah, okay, great. Thank you, Dr. Declercq and Dr. Campbell. I think I just want to take a step back and take us back to 2018. So this was the start of the Murphy administration. And this is where the status of maternal health outcomes were in New Jersey. I think both Dr. Declercq and Dr. Campbell have referenced it. New Jersey's maternal health outcomes and disparities were among the worst in the US. It did have the 4th highest maternal mortality rate in the country. And what was most alarming was that Black women in New Jersey experienced 7 times the rate of death from pregnancy-associated causes when compared to their white counterparts. We also looked at that time, the severe maternal morbidity, and in New Jersey, the rates of severe maternal morbidity among Black non-Hispanic women were nearly 3 times greater than those of non-Hispanic white women. The Murphy administration then launched in 2019, Nurture New Jersey under the Office of First Lady. And there were 35 pieces of legislation that were signed that focused on improving maternal health outcomes, focused on family planning, Medicaid, health equity, substance use disorder, and data innovation. And I'm going to spend a little bit of time on the data innovation pieces. The first one was establishing the New Jersey report card of hospital maternity care, establishing the New Jersey Maternal Care Quality Collaborative, that's a mouthful, and retooling the New Jersey Maternal Mortality Review Committee. It also then established the New Jersey Maternal Data Center. And for the purpose of this discussion, I'm going to focus on the report card and the Maternal Data Center. The hospital report card was under the legislation PL 2018 C82. And it was indeed the first in the nation to generate a report card of this nature. The legislation required the Department of Health to annually produce a report card that should include the number of vaginal deliveries performed, number of cesarean deliveries performed, and then rate of complications, along with some measures that vary by whether it was a vaginal delivery or a C-section. The purpose of this report card was to provide an annual assessment of hospital performance and outcomes, and to then report hospital-based performance and outcomes with the intent of providing education to the public. The goal was to provide the public with those annual adjusted rates and the ability to then drill down to specific populations. We've received a lot of feedback that the intended audience, being members of the public, have had some issues in accessing the website. So if it's okay, Cecile, I'll just go into the website itself and do a quick walkthrough. As soon as I'm able to locate it. Can everyone see the report card? Okay. This is the landing page for the Maternal Health Hospital report card. And if you look at the map here, it does point to every birthing hospital in the state of New Jersey. And I will click on, not to pick on any hospital, but the first one that I could see. When you get to the hospital page, the first section you'll see is hospital characteristics. So it'll tell you the name of the hospital, what is their perinatal designation, what county it's in, and in that year's report, so this is 2019's report, how many delivery hospitalizations there was at this hospital. The next tab looks at patient characteristics. So what was the average age of the mother who gave birth at this facility? How many of them were first-time moms? What was the prevalence of diabetes for the population? Hypertension, their preeclampsia rate, and what percentage of the delivery hospitalizations had pre-existing anemia. It also provides a racial ethnic breakdown of the population served. So in this hospital, 48.7% were non-Hispanic white, while 9.8% were non-Hispanic Black. Additionally, we're able to pull this information for their health insurance coverage. So in this hospital in 2019, 89.5% of the deliveries were covered with private insurance, while about 8% were covered by Medicaid. The remainder of the tabs now go into more of the clinical measures. So what happens during labor? And this covers cervical dilation at admission and procedures that were conducted during labor. If we then go on to the next tab, this is for in-hospital obstetric procedures. So what percentage of the deliveries in this hospital were vaginal? What percentage were cesarean? And what percentage was a vaginal birth after cesarean? We also report out trial of labor, whether trial of labor was conducted for cesarean deliveries. And then we look at the nulliparous term singleton vertex cesarean deliveries, laceration with instrument, laceration without instrument, and episiotomy. The last tab on the report card looks at risk-adjusted obstetric complications. And this is where it goes into the SMMs, infections, obstetric hemorrhage, and an indication of whether the rates in this hospital were significantly higher when we compare it to the state average, that there was no significant difference compared to state average, or whether the rates were lower, significantly lower when compared to the state average. And so you can see for this hospital, for all but one metric, there was no significant difference between their rates and the state average, except when it comes to obstetric hemorrhage for all hospitalizations. I'm going to stop sharing now and go back to the PowerPoint slide. But while I'm doing that, just by indicating on the chat, let me know how many people on this call found that helpful if you're looking at it from a purely consumer standpoint or a member of the community. So I'll give you my personal take on it as a non-clinician, but someone who has been in the maternal health data space for a while. It is confusing and it seems to be very heavily focused on clinical measures. Which takes us to, yeah, Betsy, that's right. That's the feedback we have gotten. It's hard to digest for general pregnant or parenting population. Which takes us to the next piece of legislation, which was passed in 2019, that requires the Department of Health to establish a maternal data center. How is this different from the report card? You'll see under the purpose, there are a few words that I have highlighted in red. Number one, timely data. Number one, a focus on quality improvement. And number three, focus on automation. What the maternal data center has now been viewed as is the one-stop shop for all maternal health related data. In the Department of Health and indeed in all state agencies, everyone owns a little piece of maternal health and maternal health data. This is of course focused on data that the New Jersey Department of Health has authority over. And it is it serves two purposes. Number one, being able to pull in timely data from facilities where these births are occurring. So you notice that the report card that I showed you was from 2019, because that's how long it takes for us to pull data from birth certificate, from hospital discharges, to be able to make sure that the data is complete, to do the manual matches, and then of course it has to go through several rounds of internal review before it can be shared. By the time the data is then shared, it is several years old, which makes the data less actionable. Not to say it doesn't have a value, a retrospective value, but it's not timely to be able to drive data to action effectively. What the maternal data center and the work that we're embarking upon now is to be able to pull in an automated manner, data from the hospitals to be able to do some of those linkages and matches in an automated real-time fashion, and then feed back that data to the hospitals, where each hospital is able to see their data in real time to be able to make changes. 90% of the challenges, and I think both Dr. Campbell and Dr. Declercq made reference to this, 90% of the challenge sometimes is getting data in a real-time manner and getting data that is reliable and accurate. Pregnancy checkbox is a perfect example, and I believe the last time we looked at it, Dr. Campbell, 30% of the time in the death certificate, the pregnancy checkbox in New Jersey is checked incorrectly. So there's a whole quality improvement part of it, but it's hard to drive quality improvement if the data is not coming in a real-time manner. So that's where the Maternal Data Center comes in. And we're also looking at other sources of data. The birth certificate data and the hospital discharge data are very valuable, and they cover every birth and every hospitalization in New Jersey. However, as Dr. Campbell pointed out, quantitative data and data from administrative data sets don't tell the whole story. We do have in the Department of Health the New Jersey Pregnancy Risk Assessment Monitoring System, or the New Jersey PRAMS. It is a CDC funded project. 1 out of every 50 women giving birth each month is selected for the survey. We do have more than 70% participation rate in New Jersey, and it captures feelings and experiences before, during, and after pregnancy. The topics include everything from maternal and infant care to sleep practices, breastfeeding, home visiting services, and more. We also have access within the Department of Health to programmatic data that speak to a bigger chunk of every pregnant and postpartum woman's life beyond the event where she showed up at a hospital. When we look at preconception health, when we look at prenatal experiences and postpartum experiences, we do have programmatic data that captures some of those experiences, some of those referrals, and some of the actions that were taken subsequently. The Maternal Data Center is hoping to combine all of that data to provide a more holistic view of the experiences and the outcomes related to pregnancy and postpartum. This nicely ties into the First Lady's Nurture New Jersey strategic plan, where there is an entire section dedicated for data. And this one recommendation was to generate and more widely disseminate data and information for improved decision-making. A lot of this does focus on the Department of Health and the data that the Department of Health houses, and how we not only combine different data sources and link data sources to be able to tell a bigger story, but how we then democratize the data for wider audiences. And so when we look at the Department of Health, what we consider the maternal health reporting ecosystem, we are looking at electronic birth certificate data, hospital discharge data, fetal deaths, and other vital records. We would also be looking at programmatic and registry data, as well as screening and mortality data. And this is all going to feed into a standardized output of maternal specific metrics through the hospital report card, and then through a broader data center to be able to look at hospital facing data, public dashboards, and then interacting with the MCQC and the MMRC through internal dashboards that can help drive policy and action. And this is just a snapshot of what we are proposing under the legislation as an extension of the work that we have been mandated to do, but to take this opportunity, given the focus on maternal health, maternal morbidity, maternal mortality, to be able to move it forward in a more effective way. Thank you.
Excellent. Thank you so much. That demonstration was really helpful. And I see in the chat that many people have found it helpful as well and shared their experiences as well as feedback around it as well. So thank you so much, Mehnaz, for sharing that information and bringing us up to speed with the policy and how that interacts with the data center as well. So I'm wondering in my mind, as we're rounding up, I'm thinking to myself, has anyone's opinions about data or the thought that comes to their mind changed through this process? If it has, I would love to hear how that has shifted. We do have some questions and comments that we wanted to pose to our presenters. And one question was, could you speak more on mental health pregnancy-related deaths? What would be considered a mental health pregnancy-related death? And so anyone can jump in there to answer that question.
I mean, in the most extreme cases, it involves suicide or behaviors that might be suicide. We see that in, again, the cases I review often have substance use relationships, and there's a cycle that I suspect probably happens in New Jersey as well, of somebody who had substance issues who got cleaned up during her pregnancy to protect the baby, with the hope that this time they'll be able to keep their baby, because oftentimes there's a history of having their babies taken away by Division of Children and Families. They do a wonderful job during the pregnancy. They have a successful pregnancy, and the baby's taken away anyway because the life circumstances are still pretty challenging. And then one sees a spiral of substance use, and then you try to make a judgment as to whether or not it was a suicide or just an accidental overdose, or those kinds of things, those kinds of difficult to identify cases. So there's that. I mean, there's the more dramatic cases of events with severe postpartum depression, but at least the ones I see tend to be more in that suicidal ideation, followed by suicide attempt, followed by actual suicide. Dr. Campbell can speak to New Jersey's experience.
Yeah, definitely. Thank you. So I was just pulling up, some little bit of information, but so number one, just to let you know, one of the committee decisions when we review the deaths is, did a mental health condition other than substance use disorder contribute to the death? So that's one of the questions that we always answer. And then we also answer the question as to whether the death was a suicide. And again, everything is a little bit more complicated than it seems, because oftentimes, the medical examiner may not deem the death a suicide. It really depends on the mitigating evidence that they have. Sometimes in talking to the medical examiner, they feel sometimes that it's a heavy burden to place on the family, that the patient may have committed suicide without strong evidence, like a note or something like that, to indicate that the person actually committed suicide. So again, this is where, sometimes the collateral information could be helpful when we have informant interviews, if we have some idea of the person's frame of mind, the use of social media posts, because people don't, we're dealing with a different generation. People may not write notes, but people do post on the internet how they're feeling, and they talk about what is going on in their lives. And so being able to have access to all of that information could give us a better understanding. And then when we get to the substance use disorder, they are categorized under psychiatric disorders, because that's where substance use disorder sits. But oftentimes, again, it's a difficult situation to know whether the overdose is related to the life circumstances, particular loss of a child or anything like that, because many times this is happening months and months and months after the woman gave birth. One of the things we don't have access to is to substance use treatment records. And so again, we're trying to close up some of those gaps in hopes of having a more holistic picture to know what was happening in that person's life. Hope that helps.
And that's one of the real values of maternal mortality review committees, because if you just look at death records, if you just look, literally it's ICD codes that are associated with the death records, you rarely see anything on maternal mental health. That virtually never comes up. And you require the added investigation that happens with a review committee to get any sense of that at all.
Thank you for that thorough response. Certainly personally learned some things there. Does anyone else have any comments or questions? We do have a question here in the chat. So one question is, will categories of sex, gender identity, sexual identity be updated for maternal mortality review and data in general?
So I can speak to it a little bit. There is a legislation that will require all data, the Department of Health, both in terms of how we collect data and how we report data, to have a sexual orientation and gender identity component to it. We're currently looking at the scope and the impact, because as you know, in order for that data to be generated, changes will need to be made on the systems end of the providers who are inputting the data, and changes on the DOH end to be able to receive the data. There will also need to be some standardization in definitions, because there are many, many definitions and many, many variables that speak to sexual orientation and gender identity. And if we get one chance to standardize that, if we don't do that now, we won't be able to compare data across providers and across facilities. So all of that work is going on right now, but we're not yet at a stage where we can start collecting or reporting out data with sexual orientation and gender identity captured. But that's a great question.
Excellent. Thank you for that response. Next question. What would you need to get access to SUD treatment records? So substance use disorder treatment records.
Yeah, that's a great question. I think with anything, the way we get records from any place is we have to get data use agreement. There's a data use agreement between the Department of Health and the different facilities, so that if we identify, the fact that a facility, was engaged in treatment with a patient. But remember, for substance use records, and so there are certain records where even when a patient signs a medical release form, the facility can't just freely share the patient's records. It has to be with the patient's permission. And so this presents a little bit of a challenge, because obviously the person is deceased, and so they are not able to give that consent.
Thank you for that response. So the next question is there a way to access the data behind the website for computational analysis? We can use machine learning to look for causal trends, not necessarily apparent given the number of confounding variables. I guess that would be maybe a question for Mehnaz.
Sorry, can you repeat that question?
Sure. So is there a way to access the data behind the website for computational analysis? Then it stated that we can use machine learning to look for causal trends, not necessarily apparent given the number of confounding variables.
Just to go back to the report card, all the rates that you see there does adjust for confounders, and it risk adjusts so that you're not comparing apples to oranges, because every facility has its own nuances, both in terms of services they provide and the patient population that they serve. So all of that was accounted for in the methodology. But I think right now what we are doing is taking a look at the report card as is, and trying to identify areas for improvement. I hope I answered that question, but I wasn't sure if the question was whether they can get access to the underlying data, or if we had made accounts for differences that might pop up, if not adjusted, would lead to different conclusions.
You can ask a follow-up question if it did not answer it. I do want to be mindful of our time, so I'm going to ask one more question. What is the role of qualitative and community engagement data in data expansion education efforts?
Can you
I
repeat
think the
question?
silence is partly because we don't do enough qualitative work. That was a symbolic answer from the three of us on that. It's a really good point. And, to a degree, there are some maternal mortality review committees that are doing follow-up interviews with families in these cases. And that's a possibility. The work I do with others on the Listening to Mothers surveys, we've always tried to have focus groups associated with those, though those are hard to pull off, but you can at least get more depth from those. The PRAMS data is, somewhat, it's a survey, it's somewhat qualitative, though it tends to be pretty public healthy and not, and by that I mean not really getting into a lot of issues. Of late, they've been much better. They've added a sequence of questions on discrimination during labor, so that's a possibility. I think we're getting there, but we're getting there slowly. That's the issue for all of it. I kept looking at really good questions. That we just don't have good answers to. I just saw another one pop up. Can I request Listening to Mothers in New Jersey like California? I wish. You can have, we give away the Listening to Mothers data if anybody's interested. We give away all the data from that, but we just got funded to do one in California. We're in the process of trying to, I think we're close to raising the funds to do another national one, but there's not big enough samples in the states to do much with states on that. PRAMS is still the best source for state data, but again, it tends to ask a lot of questions that aren't really directly related to birth, but related more to public health systems and pregnancy.
And it's analyzed in a very, very quantitative manner as well, Dr. Declercq. That's the other issue with PRAMS.
Mm-hmm. Excellent.
But we do have we did have a small pilot with the NAACP, looking for interviewing mothers, and I think there are efforts to try to bring kind of other types of evaluations of care to New Jersey. So I think people are thinking about it. It is in the works. It's not being ignored.
Mm-hmm. I think that's a great way to segue and sort of end here, because one of in our second, thank you all for attending this first session, right? So our second part is going to be community solutions and birth equity. And one of the organizations that uplifts narratives among birthing people in their community, so including doulas, dads, partners, etc., is the Earth app. And Kimberly Seals Allers will be here on March 9th to discuss that and talk about that more in depth. We'll also have Javane Santos of My Lua Health that deals with maternal mental health data. And Dr. Nastasia Harris of the Perinatal Health Equity Initiative. So if you haven't signed up for that yet, you can go to the website, birthequityalliance.com to sign up for that and to hear what they have to offer and ways in which that we are looking at narratives and qualitative data in order to turn that over and utilize in communities. So with that, we did have one other question, I think, but we are at time. So I do want to be respectful of our time. But one of the question is, how does one become involved in efforts mentioned at these agencies, data centers, and what preparation or degree program is preferable? So for those, if you have time to listen to the answer or to share the answer, please feel free to do so. That was the last question, so.
Yeah, and I see that, I just want to say that Linda, who's on the call, who is the vice chair of the MMRC, did mention that in New Jersey, we are doing informant interviews. And so that's also our way of getting some qualitative data. And we have been successful in getting some interviews. So we're happy about that. And it's always very insightful for the committee. I think in terms of ways to get involved, there are a number of ways, and we're always looking for, it always seems like, the same people in the same spaces. So, happy to share my email information. We do have a community member, a community advocate spot on the MCQC. So if, that's something folks might be interested in, reach out to Cecile and she can connect us. And then, because it's a legislative process, you have to submit your resume and things of that nature. But I would also say, reach out to your consortia in your area. There's definitely lots of ways to get involved in this work.
Excellent. That's perfect. So this video will be shared out to everyone who registered. And so you'll be able to review it, as well as some slides that were shared by the presenters. Thank you all so much, Mehnaz, Dr. Campbell, and Dr. Declercq for being here, for sharing this information and answering the questions. And for everyone who joined the call, who's interested in learning more and sharing information and asking wonderful questions. So thank you so much, and hopefully see you at part 2 on March 9th at 12 p.m. And everyone have a wonderful rest of your day. Take care.
Thank you.
Thanks, everybody.
Thank you.
Stay warm.